in the main room, I think. Can you grab it for me? Blue cup, light blue. Yes, thank you very much. Good morning. Good morning, everybody. Eva brought me my coffee. It's huge. For the morning, and I hope I'm trying a little experiment here with good morning, First Selectman. Good morning, guys. So I am doing a quick live chat this morning, and I'm going to be talking about testosterone. I'll be talking about testosterone, and I'm doing it from my hyperbaric chamber here because it sounds good, but I'm also doing it from the chamber because I am actually moving the chamber out of the office. We need more space in the office, and so the chamber is relocating. And it got me thinking today as I was driving in, and every morning when I come in, I try and listen to a podcast or a YouTube. I would try and educate myself, and it also helps me with other creators that are physicians learn about what they're seeing in the field. And so I wanted to talk a little bit today over something I've been taking care of for probably, I don't know, maybe 15 years since I left Yale, which is the epidemic of hormone deficiency. Testosterone deficiency, as well as women's hormones, are dropping. Women are getting less testosterone unless they have polycystic ovarian syndrome. Men are getting precipitously less testosterone over life. And is that a good thing or is that a bad thing? Well, one thing we know for sure in men, with recent data that has just come out, untreated hypogonadism, untreated low testosterone in men is a big problem. It increases your risk of heart attacks and it increases your risks of stroke. And I'm going to tell you a story. So sit back and appreciate the story. So I had a patient who had low testosterone, and this patient was widely loved. He was a civil servant, but he was also suffering the effects of having a very, very low testosterone while trying to build muscle. And he was building muscle. And what happened with this patient is very interesting. He had used anabolic steroids as a boy. So one of the big problems with the testosterone epidemic that we're seeing in younger men does include prior use of anabolic steroids that crushed their hypothalamic pituitary axis. And it was a big problem. And so I gave him hormone replacement therapy. Unfortunately, as he was lifting weights and doing bodybuilding, he was doing bro science as well. Bro science is where they take all sorts of stuff, peptides from God knows where, different countries, different chemical companies, and they don't tell their physician. And so there's always this challenge. And this is why a lot of doctors don't like to give men, especially bodybuilders or athletic men, testosterone. But now we know the data. If you don't treat their testosterone, it actually increases their risk of heart attack and stroke. But at the time, with this beloved civil servant, he was taking all sorts of extracurricular things. He had come to me. I'd been taking care of him and tracking his levels. We'd keep him in the right zone, but he died suddenly. What was to blame? Well, his coworkers in his department automatically want to blame the doctor for giving the patient testosterone. So one of the things you may see is a lot of doctors, especially in their 40s and 50s, don't ever want to go anywhere around treating patients that have low testosterone. Why? Well, guess what? You get a knock on the door, right? Hello, this is the local drug enforcement agency. We heard you're giving people anabolic steroids. Okay. And so for years, that would happen. Doctors' livelihoods, they lost licenses giving people testosterone, trying to help people heal. So one of the biggest problems in men, also in women, but especially in men, is that doctors don't want to touch testosterone because they're worried other civil servants are going to kick their doors in, end their livelihoods, strip them of their license. Why? Because they were trying to help patients with testosterone. It's not like they were running a pill shop with opium or with oxycodone. They were instead giving patients testosterone. Okay? They were giving patients testosterone because they had low levels. Now, in this case, this cautious scenario, the civil servant was using extracurricular things on his own. So when the state DA came into my door and harassed me, they insinuated, and this is a very difficult thing in my state where I am. I mean, I'm in New York and Connecticut. Also, I'm licensed in South Carolina. But in Connecticut, they actually send pharmacists to the police academy, which apparently turns them into, I don't know, a fantastic police officer. And I don't think it does. In fact, I think it promotes power without proper guidance. And so what you end up happening is a lot of pharmacists policing physicians. And those pharmacists may have never trained under clinical care. They may have had a little bit of clinical care, but they go to the police academy and pretty soon they're kicking down doctors' doors for giving testosterone. Well, at the time, the FDA still had a black box warning on testosterone. That black box warning was actually removed just a couple of months ago to educate all of you. Testosterone does not cause heart attacks. Testosterone does not cause strokes. If you have a low testosterone, you're at an increased risk of having heart attacks and strokes. And that was shown in the VA study, pretty crystal clear. Men need to have an appropriate testosterone level. Well, what's appropriate? Well, we have an epidemic of low testosterone in the United States. And when you compare where it was prior to ultra-processed foods, it was much higher. When you compare it 40 years ago relative to now, much higher at different ages. Why? Well, we have plastics, microplastics. We have testosterone signaling interference molecules in our food and in our environment. We have an epidemic of blue light. Another reason why I like to be in the chamber is I keep that aggressive, oppressive blue light away from my eyes. And so it's a really good place to kind of hang out and talk to you guys this morning. So it's one of the things I like to do. And I think another problem we have is we also have an epidemic of obesity. Obesity causes you to put on fat mass. And when you put on fat mass, you're more likely to aromatize your testosterone. What does that mean? You take testosterone, you convert it into estrogen. And that's a topic for another day I can't wait to talk about, which is the fact that not all estrogen is the right estrogen. You have a compound like estrone, which can actually be pro-inflammatory. So converting into estrogen may be a good thing, maybe not. We used to actually, when we gave testosterone, we would block the conversion to estrogen. We also have found out that's probably not so good for you. So in essence, in order to give people testosterone, you have to manage it. And one of the biggest problems I see out there is there are a lot of places that aren't managing. And what's the risk of going on testosterone therapy? Well, there are a few things. One, your prostate may grow. I did not say that your prostate will get cancer. I said that your prostate may grow as a man. Now, when I give them testosterone therapy, I'm not worried about the prostate growing, right? It's just not a worry. And it's important. Women need testosterone too, but for men, prostate may grow. You may have symptoms. Those symptoms include a little reduced stream in urination. Often that's due to the fact that you probably have too much what we call alpha DHT. All right. So when we have that, that's a molecule that will cause your prostate to grow and your hair to go, right? So it'll make your hair grow a little bit, like go, not grow. It'll make your prostate grow. In addition to that, one of the other things that we see in men is that they may have what we call erythrocytosis. I do see this in women rarely, but more often it's men because they're at higher doses. What happens is that your kidneys increase their secretion of a chemical called erythropoietin. So if you do some adequate blood work, which includes testing erythropoietin, you can actively track before the erythrocytosis, the big red cell count comes. Well, don't you want a red cell count? Well, yeah, we all need red blood cells, right? We need to carry oxygen. And is there a benefit to having a higher count? Well, in longevity, the answer is not if that higher count comes with a higher iron level, because iron accelerates aging. But if you can have a higher count without being anemic, without having the adverse effects, it actually helps you exercise. And so it's a natural consequence and kind of a feedback loop with testosterone and erythropoietin. In addition to that, the high count comes up. The risk there is that it's too high. Well, what's too high? 18, 19 hemoglobin? Well, in those cases, you can actually encourage people to donate blood. And so that will bring their levels down a little. Can you live at an 18 or 19 and be pretty safe? Yes, the data shows that. However, some people like to bring it down into around the 17 range. And so you will give donations. And it's funny. I often think about donating blood now and donating spike protein, right? If we're still making spike protein in our body, which by the way, we still don't have an assay for, you donate blood and you give spike out. And so why is that an issue? Well, spike protein from COVID is implicated in something called hypophysitis. So one of the things in the epidemic of low testosterone that we've seen is pituitary dysfunction. And I saw that testing patients who were acutely affected with SARS-CoV-2, their testosterone would go through the floor. I take care of a bunch of professional athletes, and I saw their levels plummet. Subtherapeutic levels in professional athletes go from 700 or 800 to 200 during the course of acute infection. Is there a natural drop a little bit with cytokines? There is a little bit, but not to go from 900 to 200. And what we found was that SARS-CoV-2 causes the pituitary gland to inflame. And that inflammation causes a dysfunction. Very similar to when you get a concussion or a traumatic brain injury, you have pituitary dysfunction. When that happens, there's no longer a signal from your brain to make testosterone. And when you don't make testosterone, you should climb. Those signals should climb because everything in your endocrine system is a feedback loop, right? So too much of something, it tells you to be quiet, stop signaling it. Too little of something, and it starts to speak up and ask for that hormone, whether that's thyroid, whether that's estrogen, whether that's testosterone. There are a whole series of feedback loops in our endocrine system. It's really brilliant that way. So the epidemic of low testosterone will continue. Doctors will continue to be scared to treat it because they'll be prosecuted for treating low testosterone. Even without the FDA black box warning on testosterone, there are still going to be zealous pharmacy police officers that believe strongly in enforcing our laws, which I think is good. There's nothing wrong with enforcing our laws, but I think you have to do it in a way that is summum bonum, right? For the greatest good. And depriving men who have low testosterone of testosterone probably is not for the greatest good. Probably is not. It increases risk of heart attack. It increases risk of stroke. That's number one. Number two, there's this mission creep, right? If I'm enforcing a controlled substance like opiates, which could be a big problem in society, I also have to enforce Adderall. I have to enforce testosterone. Otherwise, it looks like I'm selectively enforcing controlled substances. I don't know whether that's a good policy or not. I'm not a policymaker, but I would recommend that the epidemic of hypogonadism in men also is an epidemic of hypogonadism in women, and we need to treat these hormones just like we treat thyroid. Think about it. Why is estrogen not a controlled substance, but testosterone is? Because of its risk of abuse. There are a lot of other anabolic hormones out there that probably should be regulated that way. Winstrol, DECA, Tren, bodybuilder hormones that have less salubrious effects than testosterone. So that's my pitch today. There are a bunch of you on right now. I wonder if you guys can even chat on this or talk about what's going on, or can send me a message. I'm happy to answer you. I've got to get off in a couple of minutes to see patients. But the one takeaway from all this is to criminalize the treatment of patients with low testosterone is going to destroy society. It is going to rip societal fabric at its core. It is going to increase the risk of heart attacks and strokes in our young boys, increase the risk of heart attacks, strokes in our young men. Now, I'm not saying give young men testosterone. I'm saying track their levels and make sure that their blue light, make sure that their environment, make sure that their toxin loads are low, get them to bed at the right time, allow them to take risks and develop and grow, and get them outside, and we'll see those levels start to come back up. Will they ever come back to where they were before we had ultra-processed foods? I don't think so. I think we have to get rid of ultra-processed foods, and I think we have to dedicate our lives to focusing on circadian health for our young men and for our young women. And we need to stop criminalizing the use of testosterone to help people achieve vitality, longevity, and a life well lived. That's my take. I hope you guys have a wonderful day. Make it a great one. It's hump day. Remember, if you want to help your children, your spouse, have a life well lived, think about their hormones. Even at a young age, track their hormones. The environment that we're in is an obesogenic environment that promotes conversion of testosterone to estrogen in young boys. And that's a big problem.